So my career in behavioral health actually started when I was a psych tech. And I was a psych tech at the old St. Mike's, which was right here on campus. And OT in particular was a significant part of our hospital program. And it was there that I really learned the value of occupational therapy as it relates to behavioral health. And as Thomasine was talking about, just the interdisciplinary opportunities to help patients by merging all of your expertise. It's just so important. So today we'll talk about suicide risk assessment tools, how to talk to patients about suicide. So this will be an overview, and then we're going to have a panel discussion. And the objectives are just to identify the common screening tools, look at basic elements of suicide risk assessment, and then recognize general risk, protective risk factors regarding suicide. Now, I'm cognizant in training people and having been trained in suicide risk assessment, you're aware that you talk about suicide, and for some people it's academic, for others it's actually personal. So many of you have some experience with family members, friends, yourselves perhaps, who have been suicidal. And so when we talk about this, I get into the nuts and bolts of it, if you're feeling worse afterwards, process it with friends. We have the counseling center line, there's the suicide hotline, but just to remind you that it's not a benign thing to be trained. In med school, we call it in the medical school syndrome, is you get trained on something and every med student thinks they have that disease until the next program, et cetera. So, but it's not a benign thing. Being in the helping profession is actually an occupational hazard. I think we should actually do, in terms of informed consent, we should have you sign, oh, by the way, when you go into this, there's actually some hazard to it. We know that in the caring professions, there's a much higher risk of suicide. I was looking at PT and I was trying to find, is there data on that? If you Google, suicide risk and OT or PT or nursing, what you typically get is just what's the discussion within how do we train people. So there's not a lot of data on how does it actually affect you. In PT, we know that there's a significant amount of burnout. OT, I can assume the same, but I don't know if there are any articles. Are there articles, Sarah, on OT and burnout? So there's some research projects for somebody. We know within medical school that there's a higher risk of suicidality and depression, particularly for female physicians. Veterinarians, female veterinarians in particular, nursing, psychology. So, all the more important to be aware and be taking care of yourself, speaking of community and individual resilience. So, definition. So, suicide is defined as death caused by self-directed injurious behavior with intent to die as a result of that behavior. When we talk about people dying by suicide, we're now using the term dying by suicide as opposed to committing suicide. The assumption with committing suicide is that was your intention, you were all in, and the truth is, for many people, it's very impulsive. Or it's just a temporary cognitive change in how you view the world. We're using the term died by suicide. Suicide attempt is non-fatal, self-directed, potentially injurious behavior with intent to die as a result of the behavior. So it might not result in injury, or vice versa. A person might injure themselves intentionally without the intent to die by suicide, to be suicidal. Some people do that as a release of tension. Now, those individuals who do that actually have a higher risk of suicidality, but many people are not actually intending to die by suicide. And then lastly, suicidal ideation refers to thinking about, considering, or planning suicide. Sometimes we use the term suicidality, which encompasses all of the above. So I'm putting in just a few slides here that are kind of boring, but it's kind of to jumpstart our panel discussion. And so I put in slides on just general suicide risk in terms of American Indians, LGBTQ, and also with veterans and children and adolescents. So if you look, there is a trend upward, and certainly we know about that just as we listen to the news, that we know that there has been an uptick in suicidality. There's the female and male population. We know that for males, suicide rate is higher. Suicide attempts are higher with women. Males tend to use more lethal means in general, so there's less survivability. Suicide rates per age. So if you look at 10 to 14, 1 per 1,000 for girls, 3 per 1,000 for boys, and then farther up. Currently, the age group that tends to be the highest is actually 45 to 54. It used to be the geriatric age. That's come down a bit. So race by ethnicity, race and ethnicity. So we know that American Indian and Alaska Natives as a group have higher rates, and there's even been an upward tick there. And then white males in particular is the next highest group. Asian Pacific Islanders, Hispanic Black tend to have lower suicidality. That certainly doesn't mean that individually when you are working with someone in those ethnic groups that they can't be at risk, but this is just general across the population. Native American, if you look, the younger individuals, significantly high rates of suicide, and then that tends to go down compared to all of the US cohorts. LGBTQ respondents. So this looked at younger individuals in general, and high risk across the board, but much higher risk of both attempts or suicidal ideation and attempts among those transgendered and non-binary. So we know that individuals within these groups have significantly higher risk. And so we can not only be aware of that, but we can assist, we can advocate, et cetera. And then for veterans, which is one of the groups that are going to be talked about on the panel. If you look at the upper line, that's the veterans, and the lower line is non-veteran ages. So veterans in general have a much higher risk as well. If we go to the next slide, we'll look at how those individuals actually die by suicide. So in the left column, the percentage of non-veteran adult suicide deaths, we can think of that as the US population of adults. So how do the US population of adults who die by suicide do so? Almost half do by firearm. Poisoning, which is primarily overdose, is next. Suffocation, which is primarily hanging, is next. And then other. If we go across, veterans are much higher, in particular in terms of firearms. We go across next, male, non-veteran, firearms are higher among males. Percentage of male suicide deaths, firearms significantly higher. And so for women in general, and women veterans, it's still higher than their cohorts, but it's lower than the males. And so in general, males, higher risk of violent death, women overdosing, suicide, although I've certainly had patients, women patients, who have died by gunshot, et cetera. So there's an author, if you can read at the bottom of your page there, there's actually an article that refers to as allied health, and I'm not sure if that's politically correct or not. Is that okay? Because in some circles, that can be seen as a slight, but I don't see it as a slight. But so there was an author who wrote specifically to those who are not physicians but are allied health professionals in this area. So we want to think about context. When you're seeing a patient, are you in a hospital, clinic, home? What are the resources available to you? And much of what we're talking about in terms of rural, who has training, or how do I get access? And some of what we've been looking at is telehealth and lots of different ways to bridge that gap. Is there an indication of mental illness or substance use with the individual who you're concerned about? Because that increases the risk, depending on what the problem is. Has there been a recent change in terms of medical condition? And what does that mean in terms of their vision for the future, their sense of hope? Any recent stressors or losses? And in some particular populations, this is more significant. Youth, impulsivity, breakup with boyfriend, girlfriend, etc. We oftentimes see attempts in these situations. With Native Americans, Alaska Natives, the youth who die by suicide, oftentimes there are significant relationship changes there. And so there are certain demographics and populations where a change in relationship means a whole lot. For others, not as much. Hopelessness is one of those traits that you want to ask about. And then, are they actually having thoughts? So here's the hierarchy. As we think about suicide risk, are you having thoughts about death? And for the most part, everybody at some point in their life has some sort of existential thought about being here, not being here. But then it goes up to suicidal ideation. You know, are you starting to think about, suicide? And then, if so, what would I do? And, how serious am I about this? And then when I'm thinking about it, do I have the means to do so? And then do I have a plan? So that's kind of the hierarchy that we look at as we're talking about risk. And there are lots of tools that we use in terms of suicide risk assessment. So commonly, if you're working in a primary care center, you'll see the PHQ-9 used, the Patient Healthcare Questionnaire. Almost every clinic does that, and they do screening. There's the Columbia Suicide Severity Rating Scale, which we'll talk a bit about, that's gotten to be much more common in terms of asking about those issues, but not just within the medical or allied health field, but actually out in the field. And so we'll talk about a particular website that has versions for just about everybody who comes across someone who might be distraught or at risk. And then the safety pocket card, and I think you've got that, actually, was one of the handouts. So when we talk about screening, we're really talking about screening. We're not talking about assessment. We're trying to get a sense of, is there some risk here? We're not doing a full psychiatric evaluation, psychological evaluation. We're trying to assess risk from a screening standpoint so that then we can refer on, if need be, to those who might do a more extensive assessment. So there's something called the PHQ-2, which is a mini version, and that actually asks two questions. Over the past 2 weeks, how often have you been bothered by any of the following? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless? And the cutoff here, and again, it's all contextual, but they say if you score above a 3, 3 or more so, then maybe we want to ask the rest of the PHQ questions, PHQ-9. Otherwise, if people score, 1 or so, we don't go and ask them further questions. That's what some clinics use. This is a tough slide to read, but this is the PHQ-9. So this goes into a lot of extensive questions about risk. And what we're looking at is, do you have those cognitive changes that we see in depression? Do you have those behavioral changes that we see in depression, decreased appetite, energy, etc.? And then we ask about the suicidality, and then what's the risk there? So if we, and take a look at question 9, thoughts that you would be better off dead or of hurting yourself in some way. So when we go to score this, and again, the scoring is simply a recommendation. When we go to scoring, it says the less than or equal to 4 suggests the patient may not need depression treatment. Well, if we go back again, you can score a 3 when you're having suicidal thoughts nearly every day, and if you don't have those vegetative symptoms or some of the other concerns, and maybe have just one other symptom, it would be unusual, but you could probably land on a 4, be fairly suicidal, and yet people not necessarily catch that. And the point being, if you use this clinically, you want to read through and say, You know, a score of 5, no problem, or it's minimal, no worry. You want to look at that question 9. So there's something called the Columbia Lighthouse Project, and they developed the Columbia Suicide Severity Rating Scale. And this was the website that I mentioned. If you go to that website, you can find versions for teachers, for law enforcement, for EMTs, for just about any group that comes across someone who may be at risk. And they're screening tools, but they can be used actually for assessments as well as part of your assessment. So this is actually a great website to go to if you're interested in versions. So we'll walk through some of the versions that aren't as user-friendly, and I'll show you one that actually is very friendly. So this is a busy one, and this is out of Utah, Intermountain in Utah. But the questions are, so there are 6 questions that we go through. And we always ask the first 2 and the last one. Whether or not we ask 3 through 5 as well depends on how they answer the first couple. So the first couple are, have you wished that you were dead, or wished you could go to sleep and not wake up? What we refer to with that type of thinking is more passive resignation. Would it bother you if an earthquake happened and you fell, you know, or if you died in your sleep, etc.? That's passive resignation. It wouldn't bother me if I didn't wake up, versus something more active. And so the next question, you know, have you, I'll read it this way, have you actually had thoughts of killing yourself? So not passive, but more active. So if the answer number 1, yes or no, answer number 2, no, you know, you can go on then to number 6. If you answer number 2, yes, then we ask the rest of the questions. So it's tough to remember that. So if you have a little card, you know, that's great. But if you actually remember the hierarchy that I talked about, you know, are you having thoughts? Have you had some plan? Do you have intent? Do you have means, etc.? So then number 3, have you been thinking about how you might kill yourself? That then puts you in moderate risk if you say yes. Now these suggestions here, actions based on positive patient responses, are suggestions. But you're thinking that, gosh, their risk just went up, so what do I need to do? So some of them, it might be, you know, assess the risk factors, and we'll talk about those. Consider facilitation to a mental health professional, or even, you know, potentially inpatient. At this level, it's less likely, and talking with the patient. Ask question number 4, have you had these thoughts and had some intention of acting on them? So if yes, then you'll want to have someone who has expertise, knowledge, comfort level to be able to do further assessment. Have you started to work out details of how you might kill yourself? Do you intend to carry this out? So then we go to, you know, plan, and then the last, you know, has to do with means, and then what's your history? You know, have you done anything in the past? So for someone, if they say, you know, no to, or yes to number 1, and it hasn't been anything recent, but you ask question number 6, which we weren't taught to do. We used to stop at number 1 or 2. When we ask number 6, what's your history? Then that tells us that, okay, yeah, I actually did try to shoot myself when I broke up, you know, with my girlfriend and lost my job that same week. That's important information, particularly if you're finding out that person's in the midst of a breakup and their job is kind of, you know, not very solid. So that's why that history is an important piece of information. So you can see if it's relevant to today. Very busy, but this just talks about some of the language. So number 1, have you wished you were dead, wished you could go to sleep? Number 2, patient might say, I've thought about killing myself without general thoughts. And then you want to delve further. Number 3, I thought about taking an overdose but never made a specific plan. And so asking about, you know, are you feeling sad? Are you feeling hopeless? And then are you feeling suicidal? Or just asking, have you thought about harming yourself, etc. As you have no doubt heard, that doesn't compel someone on to hurt themselves. That doesn't further the risk. You reduce the risk by asking them and intervening if necessary. So and asking about what they've been thinking about is very important too, because like I said, if you're seeing someone and you know that their doctor just gave them a prescription of medication that they had been overdosed on before and they're thinking about overdosing on now, that would be very important information to know. Or if you know that in North Dakota it's hunting season, and you know that one of the things that they've been thinking about is suicide by gun, you know, that's obviously very, very important information as well. So, thoughts about, but definitely will not do anything about them. And we'll talk about those sorts of statements in a minute. So essentially this is walking down that hierarchy. Here is the Columbia in a much more user-friendly version. And so if you go online to that website, you can pick your favorite, whatever one version is best for you. And you can make this into a pocket card, you know, just like the safety pocket card. And it's color-coded for the risk. So as we talked about, and they use the last month, this past month. Have you wished you were dead? Have you actually had any thoughts? And then going through, you know, if number 2, yes, have you thought how you might? And then changing the color going into higher and higher risk, which then compels us to do something more intentional about that in terms of advocating for them to get to see a mental health professional, et cetera. There's the safety pocket card. I'm not going into that in specifics, just to know that it's commonly used as well, very popular, and you've got a copy of that. So when we talk about risk factors, there are risk factors for suicide and protective factors. And there's static risk factors, which means they aren't going to go away. They're solid, they're there. And then there are the dynamic ones that are moving and that we hope to be able to intervene on. So for example, prior attempts. You can't take a time machine and go back and erase that if somebody has had prior suicide attempts, which then increases their risk. Suicide in first-degree relatives. You can't undo that. You can't pick your families. You can't pick what your family is going to do. And then chronic physical illness, and particularly those that cause pain. If there's not much that we can do to intervene there, you know, that's a risk factor, although there certainly are things that we can do. But people in pain, particularly chronic pain, are in a higher risk category in terms of suicide risk. Then the dynamic risk factors, like anxiety, people who are significantly what we call psychic angst, they're just beside themselves about what to do, is a significant risk factor. But hopefully we can do something about that. Hopelessness is something that we can try to change, help them change. Command hallucinations. So if someone has you know, a thought disorder, if it's actually drug-induced, or if they happen to have bipolar disorder or schizophrenia, they're hearing hallucinations telling them to do something, then that's a risk factor if they're telling themselves to self-harm. Now, command hallucinations are not always dangerous in and of themselves. Command hallucinations may be, you need to clean up your room. You need to go out and get groceries. What we're talking about is the ones that are commanding to do some harm. So impulsiveness and aggression is a risk factor. And particularly a risk factor, we see that in kids, people who are using drugs, et cetera. Severe insomnia. So this is an interesting one. So if I'm talking with somebody about significant risk, I'm going to ask them about their sleep, because we know that people who have significant sleep problems actually can be at a higher risk for suicide. Now, the majority of people who have insomnia, like students, aren't at risk for suicide, but it is an added factor that's important to at least ask about. And the degree of suicidality, you know, how serious, how much intent. You know, we talked about plan, access to means. And what we do as mental health professionals, we don't necessarily always hospitalize someone, et cetera, but what we can do sometimes is we can work with the family, we can lock up the guns. You know, if that's the only primary risk, and there are other interventions that we can do without hospitalizing someone, we'll do that. But we want to know what their intention is. So protective factors, so employment, people who have job security, people who aren't in significant poverty, those who have spirituality or religious beliefs. Now, these aren't a given as absolute protection, but we know that the risk is actually lower in those groups that actually have these factors involved. Reason to live, children in the home, etc. Psychosocial supports. We know that isolation is a risk factor for suicide. Individual psychological strengths, how good are they at coping skills? Or did they have a history when they were younger of significant trauma and it's been difficult for them to self-soothe or find a way to manage? And so they may be at higher risk for the impulsivity or just not being able to plan and figure their way out. So I mentioned that we don't have someone on the panel to talk about geriatrics, but I wanted to share with you a case that I was involved in. So when I was straight out of residency, my job, 40% of my job was doing outreach to the at-risk elderly. It was a great program out in Washington State. And so we had social workers and we had nurses, and we would go out and into the community. And I had some of the best meals I ever had when they would find out the doctor's coming. They would want to, fix egg rolls or fix, whatever. So I would go out into the community. And so I went with the social worker out to one particular gentleman's home, and he was an 85-year-old recent widower. He had significant health problems. He had COPD, emphysema, and he was living alone. His family lived far away, his children. And the social worker had been concerned about him because he had looked like he was more depressed and obviously feeling alone. And so I started asking him about his symptoms. Asked him about suicidal thoughts. And yeah, I've been thinking about it. What have you been thinking about? Well, I don't know. I said, do you own a gun? Yeah. Have you thought about using it? He said, yeah. I said, where is it? He said, you're sitting on it. Sure enough, I was sitting on a loaded gun on his sofa. So I wasn't particularly pleased about that, but it was obviously good that the social worker recognized, first of all, that there was access to someone in mental health that could assist, and B, the social worker appreciated the severity of the situation, and C, that we were able to access behavioral health pretty quickly, which isn't always the case. And we do know also that particularly with older people who go on and die by suicide, that they have seen their primary care provider within the last month, oftentimes. Certainly the last six months, but many have actually the last month. That's one of the reasons why the clinics have started out with those PHQ questions, to try to make sure that we ask those and don't miss. So, how do we get comfortable asking about suicide? So we want to be empathic. We want to be non-judgmental, which is difficult. Some of us might have particular religious beliefs that may, affect how we ask. We want to be direct. We want to be comfortable enough to ask and not beat around the bush. So some of the examples, again, from the article on allied health professionals and how you might do this, asking the patient, have you lost hope? You consider running away from your problem. If it's a geographic change, that's one thing. If the change is actually, running away from this world, that's another. Have you had any thought that life was not worth living? That's a pretty good question to ask. Some people will say, yeah, but, I know I'm going to go on, and then you're asking about other suicide risks, and it's, it's negative. Thoughts about harming yourself, thoughts about killing yourself. So getting real specific. And you can imagine yourself trying to get comfortable enough as you're going through this process of asking those specific, direct questions. Do you have any intentions? What's kept you so far from doing this? That helps in terms of protective factors. Do they have protective factors wrapping around that aren't going to change, that reduce the risk? Or are we predicting, is there foreseeable change that's going to add to the risk significantly? And then talking about plan, means, etc. Poor question. You're not thinking of killing yourself, are you? So you should be proud that you asked, but that's not how you ask, actually. You want them to give you an honest answer. So, some of the things that we look at is therapeutic alliance. Do they trust you? Do they feel that you can be honest with them and they can be honest with you? You don't want to forget, however, that the therapeutic alliance isn't protective enough. I've had times where I thought, patient liked me, I was asking all the right questions, we were good. Patient, ended up dying by suicide. So we are, it's good to have that relationship. It's important, but oftentimes it's not enough. That's why we have to be objective and be able to step in and do what needs to be done during that risk period. So safety. What's the treatment setting? That's what we talked about from the start. Where are you right now? You're in the clinic. Or are you out in a rural area visiting at the home and the next provider is 100 miles away? Treatment plan. Who's involved? Is there a plan in place? Some people actually have plans, advanced health directives in terms of when I start to feel this way, this is how I'd like you to assist me, etc. And then coordination, collaboration. So some of the don'ts, don't lie. Now, if that's your only potential possibility, you're stuck, you're back against the corner, and you have to lie in that instance, I would lie. But in general, you don't want to lie to a patient. You want to be honest, develop a therapeutic relationship, but let them know what you need to do. And let them know you'll assist them in getting help. So oftentimes you'll read in the chart, patient contracted for safety. That should be supportive only to the practitioner's evaluation or assessment. So we might actually say the patient contracted for safety, but that's not enough, at least for a psychiatrist. I need to back that up in my documentation, and this is why I trust that that's true. Because there are certainly times I've had a patient die by suicide, and they told me no, they weren't suicidal, etc. My wife said, in a rather non-supportive way, do you always believe what people tell you? And the point being, no, again, we have to be objective. We have to do a nice job of doing an assessment, and that's why we're using these tools that are evidence-based that help you to ask the questions in a useful way. So, the number one thing that I learned when I was in residency was if ever you're stuck, you expand the field. So you should never feel like you're alone or that it's all on you to be making these decisions. It would be pretty rare that you couldn't call someone up or you couldn't ask for assistance when you're feeling stuck like that. So you shouldn't be the one that's making the decision all by yourself and nobody else is aware of it. There are times when I would bring someone into the office, one of my colleagues, one of the nurses. I've been very well trained, but there are times where I was thinking, I'm not feeling comfortable here. I'm going to have somebody else come in, and we're going to talk about this. And so you should never feel stuck that you're the only one making this decision. So what we did was we talked about screening. We talked about the hierarchy of risk, thinking about it all the way up to plans and means. Talked about interventions. And we talked about a little bit about how to talk about suicide. Any questions for me that you want to get off your chest right now? I think for some families, they're entitled to privacy. There's still the issue of shame. I think we are seeing a shift in terms of people's willingness to talk about mental health issues, stigma, etc. We're seeing more celebrities talking about that. We've got the suicide awareness walk, and so there's more and more discussion. We're paying more attention to behavioral health issues. But I've certainly seen the same thing. I have seen some obituaries where they talk about it pretty specifically. Not only in relation to suicide, but about mental health issues in general. And so on the one hand, I think that's been very useful, but on the other hand, I remind myself that families are entitled to, say what they want to say. But yeah. Yeah, well, I think that when in doubt, if you're not comfortable with where things are at, I think it's very reasonable to say, I need to, I'm really unsure of the situation here, and I really want to run this by somebody else because I'm concerned about you. Now, there are times when I've had patients just take off, and then you have to call up law enforcement, et cetera. But most of the time, I think people would say, they might argue a little bit or say, no, don't bother, I'm fine, I'm fine. But if you are feeling this just isn't right, then yeah, I think it's very reasonable. Now, the places you can call with them the suicide hotline. You can call up every human service center in the state has on-call as well. There's First Link, which is our local suicide risk assessment. And so those are, if for whatever reason you couldn't intervene then, I would let somebody know as soon as possible, this is happening, this is my concern, et cetera. Even today, for me, there are some situations where I still worry over the weekend about what is going to happen with this patient that I saw, et cetera. Most of the time, just based on my training, I'm more comfortable. The other thing is that you need to be aware of that there are, and it's state by state, but there are statutes in terms of involuntary commitment. That if someone is at such risk that they really do need to be assessed, that there are provisions within the states as far as do they meet criteria for the need for assessment. But my response, Cindy, I think would be you let the person know you really need to pick up the phone and talk to somebody because you're just not feeling right about the situation. And oftentimes they'll respect that. I mean, they understand deep down, and that's where the therapeutic alliance is so important. If they're just intent on doing something, then they may not be cooperative, and then that brings up another issue. But that was the whole idea of when you're stuck, you expand the field. Do you have other thoughts about that?
It's hard for people to know what to say.
Yes.
And you don't want to deny their feelings.
Yep.
And it's hard to have a sentence
right.
to respond, to just let them know you heard them.
Right.
And then,
yep.
If it's imminent, then absolutely you got to make a simple call.
Exactly.
If you know it's not imminent,
right.
and they just need somebody to hear them,
yeah. Yeah.
It's hard for people to find the right words.
Right. Yeah. And so part of it is making the decision in the here and now. What do I have to do? But for many people, it's like if we could help you if I could help you get to see a therapist next week, would that be okay? And what do you think the weekend would go like for you, et cetera, et cetera? And talking about the suicidality. And I think that that's reassuring. For some people, it's an immediate, or there's been recent changes, and understanding that and helping them to get help is one thing. It's really difficult if the problems have been fairly chronic and the person has been fairly consistently suicidal, and then that's another difficult situation. But I think the whole idea about learning about screening assessments is figuring out where they land, and if they're higher up, then we're kind of compelled to do something more. If they're lower down, and that was actually one of the comments by police saying, we don't want to be doing these screenings because then we're going on record essentially, and Columbia said that's exactly why you should. You can say, I asked these questions, this was where they landed, this was my response, and that's evidence-based. And we don't always make the right decision. One of the important things is, did we know what we were supposed to do and did we do that? The outcomes may not always turn out the best, but if we actually did what is evidence-based, that's actually reassuring. And so that's one of the reasons why we're encouraging these screening tools that are evidence-based. And that's why they're actually proliferated to other areas in the field, is because people are feeling more comfortable where the scores are and where they land. So, all right, thank you very much.